my name is Cassandra Romas, and welcome to 30 Medical Minutes. Technological advances in medicine continue to amaze me. Today on 30 Medical Minutes, Dr. Domenico Savatta, urologist, will discuss the advent and advancement of robotic surgery. What does that mean? It means that Dr. Savatta is a highly trained and skilled surgeon used to using a robotic machine with mechanical arms to perform surgery that was previously done manually. As an attending physician, Dr. Savatta routinely performs robotic surgery at Overlook Medical Center in Summit, New Jersey. Today we're going to learn how the robot works, the advantages of using it, and even have a peek at this piece of equipment in action. We will find out who is qualified to undergo this kind of surgery and why a patient should consider it. I can't wait to speak to Dr. Savatta, so let's welcome him to 30 Medical Minutes. Welcome to 30 Medical Minutes, Dr. Savatta.
Thank you very much, Cassandra.
Dr. Savatta, why don't we start off with you giving me a little bit of your background and about your specialty.
Well, thanks. I trained at Indiana University for urology, and the main reason why I went there was to learn how to do cancer surgery. So I started training in 1997, and while I was there, I did a lot of open cancer surgery and testicular cancer, prostate cancer, bladder and kidney cancer. While we were there, we were fortunate that we were one of the first institutions in the country to start doing laparoscopic surgery for kidney operations. And back then, we had a camera, in the same way people removed gallbladders. The urologist learned how to remove kidneys by using a flat plate TV we looked at, and smaller instruments to put in through little keyholes to do the surgeries. With that, by 2001, this robotic surgery platform came into existence for urologists, and using my cancer training, I already had in open surgery and laparoscopic surgery. I started using the robotic system in 2004.
Okay, so let me get this straight. I mean, you were very fortunate that at your training site that laparoscopic surgery came in and the use of this beginning type of surgery. So we have this robotic surgery piece of equipment that is now being used on a routine basis. But what is its history? When did it start? How long ago did it become kind of the norm to use?
Well, it's actually an interesting story. The reason why the robot first came into existence is somebody had the idea that in the battlefield, when their soldiers get injured, it'd be great if we could operate on them on the field. So they developed a robot that could actually hold instruments and perform surgery that a surgeon would be able to control from a distance. And the problem back then was having this heavy piece of equipment go through the battlefield. You'd have to actually apply it to the patient to be able to do surgery, and it wasn't really portable, and it's very heavy. So even though it's possible now to do surgery at a very large distance, the military kind of abandoned that and gave it to private industry. And
oh, I see.
so then, it was an application that looked for a use, and people thought maybe cardiac surgery would be the way to go, since you have a small area to get into the chest. And with these robotic instruments, we thought we can do bypasses and valve surgery, and that was the first application.
Oh, okay. So it started out in the cardiac field.
That's correct. And the problem with cardiac surgery is it's such high precision, and if there's any bad outcomes, it could be a fatality, and it was very difficult to use, and it's a relatively small area. So the cardiac surgeons, some of them did use it, and then the urologist said, well, maybe we can do this for our prostate cancer surgery. And in 2001, they did the first robotic-assisted prostatectomy. Over time, the same type of robot's been in existence, but it's evolved with better instrumentation and a fourth arm. When we first started using it, there was only instruments to burn things with. We couldn't cut anything. There were no scissors. So by 2003, we started getting into better equipment to actually do surgery like we would do with open surgery, with the same type of instruments, the scissors and the sutures. And once we had all that, I looked into that, using that for my surgeries, and started doing prostate cancer surgery with it first.
Wow, this sounds like an incredible piece of equipment that you're saying can cut, it can suture, it can sew up, and wow, totally amazing. All right, it seems to me that you have to have a tremendous amount of training to be able to do something like this. Is there a specific course or training field that you attend and have to continue to attend to be qualified for this?
Yeah, Currently, there's a lot of ways to learn how to use the robot, and most residents in training will have exposure to it now since it's so prevalent. There's also training simulators where they can actually practice sewing on the robot and have video superimposed, and there's certifications that we need, and online courses. And one of the great things about robotic surgery, since you can capture it on video, other surgeons can look at videos and look at their own videos and see what they could have done different or what else they can add to the surgery. When I started using it in 2004, it wasn't like that. There were only a few robots in the country, and I went out to Indiana to get my formal training, which was a 2-day course where we operated on the robot with our surgical team. And fortunately, I already had an extensive background in open and laparoscopic surgery, so for me, after that 2-day training course and several proctors that came in for the beginning to help us use the equipment, I kind of was on my own to learn how to do the surgeries, and then I took most of the operations I did in other ways, and then I converted them myself to doing it the robotic way.
Well, okay, so I hear that you had training, you continue to have training, and of course experience keeps on building and everything like that. Well, Dr. Savatta, I want to thank you very much for inviting me to the OR. You invited me to come up to Overlook Medical Center, operating room number 6, where the Da Vinci robotic piece of equipment is located along with the console. And because of that, you gave me a demonstration about how it is used and the fascinating movement of the mechanical arms up and down and picking up the tiny sutures and everything like that. So I want to thank you for that. And you know what we're going to do? We're going to go to the videotape right now. And we're going to show our audience exactly what you showed me. We were just talking about earlier about this extraordinary machine, but this looks like the main spot. This is your controlled headquarters. So why don't you tell us what this is all about?
Okay, thanks, Cassandra, for coming all the way to the operating room, because to see it is to understand it is hard to describe. So robotic surgery essentially is a surgeon doing surgery, and it's not that much different than open surgery in what we do. We try to do the same operations the same way by removing the same tissue or connecting the same structures. What it does, though, it allows us to operate in a way that's very natural for us, with our hands doing what we want it to do, see very accurately. And then for the patient, what's wonderful is they have very small incisions, so when they go home, they only have small Band-Aids, but it gives you all the advantage of doing open surgery. So by showing you the few key features and how it works, I think we'll have a much better understanding of what robotic surgery is.
Okay. So this is where you're looking in now, I presume, and you said this earlier, that this is magnifying by tremendous multiples here. So how much of a magnification do you have in this machine?
We have lenses that are in 3D, so when we look into the headset, we have 2 eyepieces. That gives us a 3D vision. The lens is magnified 10 or 15 times depending on which lenses we use. And then the nice part is, as you'll notice in a little bit, the lens gets very, very close to the anatomy. So if we're only about an inch or 2 away or closer, it's magnified 10 times versus trying to operate at a distance with our eyes, it's probably 50 to 100 times magnification.
Wow, that's extraordinary. So that is definitely gives you an advantage by looking in there rather than using a little magnifying glass over human eyes.
The way I like to think of robotic surgery is it really combined laparoscopy and laparoscopic surgery, which gave us the visualization to see very accurately, because you can see very magnified, but it was very difficult to do what you wanted to do, but this gives us the ability to do what we want to do by using our hands in a natural way and using the same kind of instruments that we had with open surgery. So it really gives you the best of both worlds.
Okay. And the reason why I'm making a big deal about this, Dr. Savatta, is because a lot of people will probably be very doubtful, feel almost maybe pessimistic or cynical that this is possible. But you are showing us that it's not only possible, but it is far advantageous to use a machine like this because of your enhanced features. Is that what you're telling me?
That's pretty much it. For an experienced surgeon, still the surgeon doing the operation, so the surgeon is still the most important thing. It gives us the ability to see in there very precisely and then do almost microsurgery, but doing the same things we would with open surgery.
Okay, fine. So now we've established that you're looking into your headpiece here, So tell us, why don't you just take us through and demonstrate a few of the features and how you would do this?
Thank you. Yeah, so this is the surgeon console, and one drawback of robotic surgery is as a surgeon, I'm actually over here and I'm not even scrubbed into the field. So the field will be over there, and theoretically it could be even 400 miles away. We could remotely operate with this unit at a great distance if we wanted to, but the way things are, it's really better to be nearby if something happens. And we'll look into the 3D headset, and then if we could, I'll show you how the instruments move very simply with our 2 fingers. Is all we need to do, and a couple of foot pedals, and I'll be able to do some intricate things on the inside. And today we have, for demonstration purposes, some rings and some suture, and I'll show you the basics of how the instruments work.
Okay, very good. So I want the cameraman to make sure that he gets a real close-up onto these rings where Dr. Savatta is going to be putting his fingers.
These are two of the controls, and we have 3 foot pedals and a side foot pedal and 3 upper pedals, and they're all do limited things. And all we do is we basically look in, so now I'm seeing everything in 3D. And the nice thing about this, with my hands, all I'm doing is doing the same motions I normally would want to do with open surgery or anybody can do. And I'm going to just insert the suture into one of our tiny rings, pull it through, and then with surgery, when we tie sutures, there's different ways of tying them. We do what's called an instrument tie. I'm going to do the same instrument ties I would with open surgery with the robot.
Okay.
And the other nice thing is that this robot, if I hit one pedal, I now have control of the camera. So with one pedal now I can move the camera wherever I want. I'm not relying on an assistant to hold the camera. The other advantage is if I want to do some retracting or do something different with another instrument, I can hit the foot pedal, and now I have my left hand switch from one instrument to the other. So essentially I have control of 3 instruments and 1 camera all at the same time. So it really lets you have 4 hands as well as your super magnified vision.
Wow, that was totally fascinating. I cannot believe what I just saw. That machine is incredible. Dr. Savatta, I can't get over what you do and how precise this whole thing is. So now that we've seen how effective this machine is, the Da Vinci machine is, tell me, who is eligible for this type of surgery?
Well, it's an operation, so the people that need the operations that the robot can help us do better are the candidates. And the main thing that I do is prostate cancer surgery. That's the most common operation robotically. I also do kidney surgery operations for cancer and benign conditions, bladder surgeries, some reconstructive urinary tract surgeries. In my field, things that I can do with other means, I've now been able to do it robotically.
Okay, fine. Any other fields that use it? You said cardiology once started. Are there any other fields besides urology?
Actually, the fastest growing area now is gynecological surgery, and there's a lot of gynecologists performing it for hysterectomies and benign conditions, gynecological oncologists that perform it for uterine cancer, cervical cancer, general surgeons that use it for colon surgery and adrenal surgery. So most fields that you can get into a cavity or a space, chest surgeons for chest surgery and heart surgery, it's all the same Da Vinci robot.
Okay, fine. So what are the advantages, the real advantages of using the Da Vinci robot? Why should we choose that over a manual surgeon?
Well, there's open surgery, laparoscopic surgery, and robotics. And robotics kind of gives you the best of both worlds, where for laparoscopy, the main advantage for the patients are the smaller incisions. It gives you less pain, less bleeding, quicker recovery. So for a prostate surgery, most people used to take 6 to 8 weeks off after surgery. Now most of them go back in a week or 2 or 3.
Really?
And the advantage for the surgeon is I can see much better into the field. So if I can see with the robotics very close, I can see more precisely. I can do what I want to do much more accurately. And the nice part about the robotics is it lets me see in there with 3D vision, like we do, and magnify. But also it's so easy to use. You take your 2 fingers and control the controls, and whatever I think of doing, it makes it much easier for me to do. And it's much more comfortable for me to operate. So if I'm more comfortable and it's easier to do, hopefully the outcomes will be much improved to overdoing it in other ways.
So when you're talking about cancer, doctor, you're talking about tumors, and you're talking about a very tiny opening that you're so proud of, actually. How can you remove a tumor from this little tiny space with a robotic arm with a little piece of equipment at the end. I just don't understand how you can do that.
Well, that's a good question. We do make very small incisions and usually 5 or 6 little tiny holes that you wouldn't be able to get a big specimen out of. With cancer surgery, we always want to keep the specimen intact. So we always take the prostate or the kidney, we put it into a sac. This way there's no contamination. Then we'll make a small incision that's usually 3 to 5 centimeters somewhere in the abdomen that's less painful. And then through that little incision, we'll pull the whole entire organ out. For benign diseases, or if there's reconstructive work and nothing to remove, then we'll have only small incisions and nothing larger than 1 centimeter anywhere in the abdomen.
Okay, so you're saying there are a lot of advantages, and I'm repeating this. Smaller incision, which means less swelling, less pain, less bleeding, a lot of accuracy, and you can still remove tumors and keep them intact. But I think as a patient, I would kind of worry about what if it really starts to bleed? How can you keep that under control?
Well, you bring up a really important point. With one of the drawbacks of robotic surgeries, I'm not directly on the patient field, and my hands aren't in there. So with open surgery, if we have a major bleeding area, we can put our hands on it and just put pressure and stop it. With this, we have to rely on our assistant or our robotic instruments to grab things and hold things, but the ability to do that is much less than with our hands. So really the first thing is to prevent those bleeding. And if you see, you have to use your surgeon's ability and your judgment that if you're going to get into bleeding, don't do that, and always convert before that happens, where you can make an open incision, still do the traditional surgery. You can still convert to laparoscopic surgery. And fortunately, out of 1,500 operations, I've never had an emergency where you had to make a quick incision, but if that ever happened, you could quickly undock the robot within 45 seconds and then within several minutes be into the abdomen with your hands and do everything you would do with open surgery.
Okay, so I'm going to repeat what you just said. You're saying that usually in your robotic surgery that you can keep all of that under control, but if something should happen, that you can convert, which means switch from the robotic surgery to regular hand surgery within seconds, and then you can get there with yourself and your team and just proceed and take care of things. I think another concern I would have is, since this is a machine and is, I suppose, working with electricity, what would happen if there was a power outage? Well, what would you do?
Yeah, fortunately in the operating room there's generators, and the odds of that happening are very, very small. I think in 1,500 operations I've had 2 experiences, not in the last 5 years, but back before that, where the robot wasn't able to continue anymore. One time we were fortunate, we had a second robot available, and we brought that into the room and finished the operation. One other time we switched to laparoscopy, because at that point of the operation we were almost finished. So you can resort back to, if you have another robot available, bringing that in. If not, switching to laparoscopy, switching to open surgery. So it's still important to be on site and have those other abilities if you need to do them. And one other important point, when you asked about converting to open, the reason why I'm able to do such complicated surgery, and I did it back in 2004 and 2005, we had a discussion with the patient. I think we can do something robotically, although maybe we never did it before. But if we try to do the robotic surgery and it's not successful because the surgery is too complicated or the patient's too obese or too much scar tissue, then we'll just convert to the open traditional surgery. So at least the patient knew they were going to get the open surgery at worst. And by doing that, several times we did have to convert to open surgery when I first started, but you realize that you can do more and more complicated surgery if you try, and we can do it very safely. So that's kind of the origins of how I developed all these surgeries robotically.
Okay, I'm getting the picture. I'm getting the picture of a highly skilled, very experienced surgeon who has the ability to choose between offering his patients robotic surgery and or I don't want to say normal, but manual surgery. And if you start one, the robotic, you could always convert and go back to the other, depending on the conditions. And or if there's a malfunction, God forbid there is a power outage or something like that, which really says a tremendous amount of wonderful things about you, Dr. Savatta, and the other physicians who have this skill and expertise. I think another question that comes to my mind is that I see you leaning over the console. Don't you get tired? I mean, these surgeries don't take 10 minutes. They take a long period of time. Don't you feel fatigue? Don't you get, tired leaning in like that? How do you feel doing that for so many hours?
With the when you're comparing robotic surgery and comparing it to open surgery, it's actually much more comfortable because my head is on a headrest and my arms are on an armrest. And most of my fatigue usually is more mental fatigue. If it's a very complicated surgery and you're concentrating so steadily on trying to do something, not really the physical fatigue. It really is as comfortable as possible in a way to do any surgery. And compared to laparoscopic surgery, where you have a camera that you're battling with your assistant to be able to hold your instruments while you're almost colliding with him and looking at a television screen that may be not exactly where you want it to be. It's actually much more comfortable than the alternative. So it's not as nice as sitting down, but it's certainly much more comfortable than laparoscopic or open surgery.
Okay. Well, I suppose what you're describing is that if you're having open surgery, the physician and all the team are standing for hours, then that's probably, as you said, far more tiring than sitting down in a comfortable chair with cushions and everything like that, right?
That's correct. There's actually studies that show that there's much less surgeon fatigue by doing the surgery robotically. And a lot of my colleagues that are older than I was, they had bad necks and bad backs from doing surgery, open surgery, and always looking down into a field. Fortunately, hopefully as I get older, I won't have those same issues that some of my predecessors had.
Okay, great. So let me just go back now and actually describe the process if somebody comes to you indicating that they have a prostate, they think they have prostate cancer. Take us through the process here. Somebody's walking into your office, your urological office. What's the first thing that you're going to do?
Well, there's two types of patients. One of them that come with symptoms like blood in the urine or elevated PSAs, and we do a regular workup like every other urologist would do to diagnose the condition first. Once you have a diagnosis of prostate cancer or UPJ obstruction or a kidney mass, then they have a different consultation regarding how to take care of the problem. And then with my work, I get a lot of second opinions of people that already have the diagnosis. So they already know they have prostate cancer or a kidney tumor from prior workups from different physicians. So when you have that second patient now with a known condition, you discuss them what the options are for that condition. And even though robotic surgery is less invasive and a better alternative than other forms of surgery, you still have to say, are there other alternatives like radiation or observation? So first always decide, is the operation of any type necessary? And then if the answer is yes, then you figure out, given your condition, can we do this robotically, and what are the alternatives between robotic, laparoscopic, or open, and then figure out what's best for that patient.
Okay, so you are transparent in showing and letting your patients know they have this choice, this choice, this choice, and depending on the particulars of their individual condition, they make a decision.
Well, honestly, that's accurate, with the caveat that if I've done over 1,300 or so robotic prostatectomies now, and I won't do an open prostatectomy because, in my opinion, it just doesn't make sense. So I'll tell them that if you want to still have open surgery, we can certainly refer you to somebody that still does this operation. But some operations, in my opinion, in my hands at least, are so much better to do it robotically. I don't feel right doing it the traditional way.
Okay, fine. Wow. Okay, so if a patient chooses to use the robotic surgery technique, how do they prep for that?
Well, when we first did robotic surgery, we had a lot of concerns with intestinal gas and giving stuff to drink to clear out the intestines like you would for a colonoscopy. For my patients, as my experience grew, I realized that those things cause abdominal cramping and dehydration. And for the most part, all I really do is have them, after breakfast the day before, just drink liquids all day, no real bowel prep, and come to the surgery the next morning without eating or drinking like any other operation. So I really did a lot less than I once first did when I first started doing these operations as the safety became more apparent.
Right. Okay, so this is treated as a regular surgical case. So your patient is prepping for surgery. They check in, they go to the OR. What sort of anesthesia do they have for this?
Well, the one thing about the robotic surgery is we have to have the patient completely still, so it has to be a full general anesthetic, where sometimes other operations, maybe you can do a spinal, which we can't do. Other than that, though, it's really the same operation. You go to the same operating rooms. This one has a robot in it, but it's really the same kind of an operation. The insurances pay for it exactly the same way, so it's not experimental in any way anymore.
Okay.
And it is still surgery. I mean, patients can't expect to. A lot of patients go home the next morning, or almost everybody does for most of my surgeries. But they still surgery, still abdominal pain and cramping. So it's much better than the alternative, but it's still an operation, and it should be treated as such.
Okay, fine. So when the surgery is going on, when the operation is going on, you're at the console. Who else is in the OR? at that time?
Well, for most operating rooms, the way they're set up, you have an anesthesia team, which you still have the same team. You have a surgical assistant or a surgical scrub nurse, it's called, where they'll actually hand instruments to the surgeons, and you have a circulating nurse that grabs instruments. So that's basically the same. The one thing we have to have with any big surgery requires a surgical assistant, and this also requires an assistant to stay at the field and swap out the instruments and put the bag in the abdomen and give suction and irrigation. So it's basically the same team as any other surgery, just the roles are a little bit different, where the surgical assistant is the main person at the field, and then the surgeon himself or herself is off to the side using the console.
Okay, so I'm going to go back to these mechanical arms and what the scrub nurse is doing. At your command, or I don't want to say command, but basically your command, you're saying, please switch from this arm, and I think there's the clamp is there, and they take it out of the clamp, and then they put in the new piece of equipment. And then they can do the different function, whether it's a scalpel or whether it's the, I suppose, tweezers, what you use to pick up the little tiny suture, or the scissors. So they can switch those in and out in just seconds. Is that correct?
Yeah, that's correct. With an experienced team, they kind of almost know what I'm going to do next. If I'm using a suture to tie something, I'm going to probably cut something next, so they'll swap out a scissor real quick. So the surgical nurse will grab it, hand it to the surgical assistant, who swaps it out into the robot. And really, an instrument change can take 10 seconds or so, just to go from a needle driver where I'm sewing with to a scissor where I'm cutting back, and then also back to the needle driver, which brings up the point, if you're having some bleeding, we tie things that are bleeding so we can quickly hold pressure, tie it real fast, and then switch back and forth and still be able to do relatively very complicated surgery in a way we're not losing a lot of blood and doing it very efficiently.
Well, it seems to me that this is totally amazing because in open surgery, you have people's hands going in there, you have them maybe leaning on the field, so to speak, and in this case, you're eliminating a lot of contact with the patient itself, maybe reducing the amount of swelling, maybe a source of contamination and infection, and as you said, the field is so tiny, the sutures are so tiny, and the point is so tiny that you can't get these little tiny incisions in, right?
Yeah, basically that's what we're doing. All those advantages you said are correct. We're able to do complicated surgery, and the interesting thing about the pain, with open surgery, you usually have pain in the muscles. Our main source of discomfort often is just the swelling of the intestines, and some people complain of shoulder pain from the gas, and that pain is actually worse than the actual surgical pain they feel in the incisions themselves.
Okay, what is the recovery time for something like this?
It depends a lot on the operation, but looking at our most common operations, the prostate surgery for prostate cancer, and most guys go home within one day, usually the next morning, with a catheter in place. I'm working on some new techniques to get the catheters out as soon as possible. So most guys leave them in about a week. I usually get them out in 3 to 6 days. And then within a week, they're driving again. And even when they go home one day after the surgery, we use the special glue so they can go home and shower right away. They can walk up a few stairs right away. So they can basically almost take care of themselves even after the day after the operation, which is pretty amazing.
Amazing. That's the word for it. Thank you so much, Dr. Savatta. Thank you so much for joining us today and learning about robotic surgery. Totally amazing is the word, and if you need to use it, consider it. Thank you.